Hey everyone, we're just going to give it a minute or so to let folks join. We have a very large crowd today. It's wonderful to see the interest in progress against sickle cell disease, desperately needed progress against sickle cell disease. So thanks. You know, I'm never good at this. I try to be patient and I'm never good. So I'm just going to get started. I think you all know me. My name is Ellie Dehoney. I'm with Research America. And thank you so much for joining today and for your partnership in the Research America Alliance. And my 15-second pitch, if your organization is not a Research America Alliance member, join us. We really need the force of your reputation, of your passion for faster medical and public health progress, and for discussions like this. So if you wouldn't mind contacting Joel, his email is in the chat or should be, just to have a conversation about whether membership makes sense for your organization. That would be fabulous, or connect us to whomever you think appropriate. So now to the exciting part. I'm so pleased to introduce Dr. Gary Gibbons. Dr. Gibbons is the director of the National Heart, Lung, and Blood Institute at NIH, and he's agreed to join us for a conversation about what is truly a grueling battle, and that is against sickle cell disease. And one more bit of housekeeping. As always, please type your questions in the Q&A box or in the chat. We'll pose as many as we can during that portion of today's session. So thanks so much for joining us again, Dr. Gibbons. And if you wouldn't mind, could we start with the basics? So kind of the quick 101 on what sickle cell disease is. I know that there's actually kind of two versions of things that are associated with sickle cell itself, and a little bit about the disease, who's most affected, that kind of thing.
Sure, Ellie. Okay, thanks for having us. As many of your listeners know, sickle cell disease is an inherited disorder. It's caused by a mutation in the hemoglobin gene, a sort of a misspelling of it. If you have one copy of that misspelling or mutation, you have sickle cell trait. Obviously you get one copy from mom and one copy from dad. And so if indeed you inherited the trait from both sides, you have two copies of that mutation. And that results in sickle cell disease. The name sickle cell relates to the role of hemoglobin is the thing that carries oxygen around your body in red blood cells. Obviously every cell and tissue of the body needs that oxygen. And one of the things that happens in sickle cell disease is your red blood cell that's carrying that ordinarily sort of flows through the bloodstream like a frisbee through the air and just sort of moves smoothly. But in the context of sickle cell disease, particularly when there's a lowering of that oxygen, it actually turns into a sickle shape. That's where the name comes from. And that no longer flows through the blood smoothly. It actually can get caught on the blood vessel surfaces and deprive various organs of the oxygen that they need to be functional. And so that's why sickle cell disease pretty much affects every organ in the body. It can cause strokes, it can cause heart damage, lung damage, kidney damage, multiple organs, the eye, etc. And that's why it's so debilitating. And indeed, one of the most debilitating elements is a sickle cell crisis, in which there's pain that's literally sort of felt deep in your bones, and again, can be incapacitating. In fact, a doctor friend of mine who has sickle cell disease told me, Gary, if I had a choice between you breaking my arm and having a sickle cell crisis, I'd prefer you to break my arm. That's the pain that they experience. and often it necessitates them coming to an emergency room for that treatment. And I'm old enough with these gray hairs that I remember that particularly many years ago, 30 years ago, really didn't have much to offer them. That these patients, some fluid, some oxygen, and basically opioids to control the pain in the painful episode. This is a debilitating disorder. And unfortunately, because of that treatment regimen involving opioids, this is also a population that, quite frankly, has been marginalized and often is felt unwanted and uncared for by the medical profession. So there are a lot of layers of challenges that those living with sickle cell disease have borne over the years. It ironically was the first molecular disorder where it was known what the molecular defect, that misspelling is. That was back in 1948.
Wow.
And so although it was one of the first known genetic molecular disorders, unfortunately, not a lot had been developed in terms of treatments. So when I was in that emergency room as a young trainee and resident, we didn't have very many treatments back in the 70s. In fact, the lifespan and what we doctors would tell parents is that it may not be clear that your child will live to adulthood. And this was not that long ago. And so thankfully, with research that funded by the NHLBI, in fact, started to lead to treatments in the 70s and 80s that involved penicillin prophylaxis, blood transfusions, the drug hydroxyurea, and these were treatments that were able to expand that life expectancy to the point of many sickle cell patients at least living to their middle age, and now in some of them into their 60s. So we still have a lot of work to do.
Okay.
And I also mentioned that this is a disorder that affects every ancestral group. In fact, sickle cell trait really probably was selected for in areas where malaria was common. And so that's why you'll find sickle cell disease amongst Italians and Greeks and others in the Mediterranean area, as well as sub-Saharan Africa.
Why is that? Why are those two things associated?
So great question. And so as it turns out, having sickle cell trait, where you only have the one copy of that mutation, actually was helpful to the body in fending off the effects of malaria.
Wow.
And so that enabled those individuals who had that trait to get less sick from that vector and that disorder. And so it was actually an advantage. And so it became more common to have trait such that that prevalence is particularly high, let's say in sub-Saharan Africa,
Wow.
For example. Now that also does mean that it's more common amongst African Americans, because obviously we're derived from those populations where malaria was in West and South Africa, in Southwest Africa, with the slave trade. Similarly, probably over 75% of the babies born with sickle cell disease today are in sub-Saharan Africa. Literally hundreds of thousands of children are born each year with sickle cell disease in sub-Saharan Africa. And one of the challenges is that 50 to 80% of those children die by age 5.
Oh my God.
Still a major problem and a major focus of the NHLBI research program, in which we're working with scientists in Africa and clinicians in Africa to build their capacity to screen for sickle cell disease and to start to use some of the treatments that have been defined over the last 20 years in that setting. And so indeed, we've funded trials for them to start to use hydroxyurea in that context, as well as other treatments.
What's striking, I think, about that, I'm sorry to interrupt, is that it speaks to the fact that research and progress, if it's not global, it's not serving the United States or any place else, right? Not only is it the right thing to do, but it's a smart thing to do to look at populations globally that, for example, have protection against malaria. And what does that mean for sickle cell in the United States? So it's really interesting. Can I ask one quick question that has to do with when I was a kid? I had a very close friend, her name was Sandy, who had sickle cell disease. She was on the basketball team. I was a bench warmer. And when she, at certain times, she would need orange juice, that something was happening and she associated with sickle cell, and they would give her orange juice. Is there something about sugar that used to kind of give a temporary boost, or was that just an anecdotal thing at that time?
It sounds a little anecdotal, but the hydration is important. So particularly if she's an athlete, and as you're saying, we're perspiring, it's really important to keep up with her fluid balance. And indeed, that dehydration, particularly, quite frankly, related to the kidney, can be a challenge, particularly in sickle cell disease.
Sickle cell.
Yeah, so that's where that probably was aligned with trying to stay hydrated as much as.
Yeah, and like you know, the grays are maybe hidden, but it was back in the day. Let's just say. But back to these questions. So NIH has done research that has brought the science along dramatically. So what is the state of research now? What's happening in the realm of progress against the disease?
Yeah, well, as you say, this is something that I've given you sort of that historical perspective.
Yeah.
And that one of the early elements of this is, and it was a high priority, certainly when I began to be the director about 10 years ago now, was really to do a full court press on sickle cell disease and to really put research on the front burner. And so that had a number of different dimensions. Certainly, there was basic science research that was really critical, particularly with regard to defining additional treatment strategies beyond sort of blood transfusion and that sort of supportive care. And that investment, I think, has paid off with really over a dozen FDA-approved drugs just over the last 5 to 10 years that have come out of that basic research. So some of the things that we described about how the sickle red blood cell gets stuck on the blood vessel wall, it was defined what are the molecules that drive that process. And that became a target for a treatment that's now FDA approved to, again, reduce the likelihood of those blood clots forming and then triggering these crises and strokes and what have you. And so progress has been made there. Similarly, we've done other sorts of science, what we call implementation science, because some of it relates to how we actually care for those living with sickle cell disease. Are there strategies we can use to reduce the need to even go to the emergency room in a crisis? Or if they do come to that emergency room, what's the best way to treat and follow up with these patients such that they get the care they need in a more continuous fashion? And so that's research that we've also funded to see that what we could do just to enhance the quality of life of those with sickle cell disease. Another area is with regard to pain. This is a key part of the suffering. And again, some of it's understanding what drives that pain. So we know it's an excruciating pain, but what could be done to alleviate it that goes beyond just giving opioids. And so understanding what are the pathways that are involved, some of which may involve a state of inflammation that we've now learned about the state of living with sickle cell disease. And so that's an area of promise where we can do, I think, even more to address agents that can alleviate that pain and a key part of their suffering.
It's something I hadn't thought about, that you actually need to be a detective to figure out what's triggering pain. And then you have to figure out how you can minimize that pain. Can I go back to something that you mentioned about targets? You know, one of our themes at Research America, we're a cross-sector alliance, is how the actual pipeline works. And I know it can be different for each drug, but or in other intervention, when you have a target, so you notice there's a stickiness and you want to do something about that, that means you have a target for some kind of an intervention. Is that typically is that intramural, extramural, NIH? Is that academia? Is it academia and industry? Is it industry? You know, where is that?
It's a great question, Ellie. And indeed, it's everybody that you mentioned. Exactly. And this is actually one of the things when we engaged in this space was to actually convene, particularly when we were thinking about curing sickle cell disease. To really tackle something this complex with these many layers of disease, quite frankly, the marginalization that I described, quite frankly, some of the mistrust that is built up over the years, as well as the notion that, you know, many of those living with sickle cell disease have a very modest means because it, again, is debilitating, affects being able to go to school and work. So many of these patients are often on Medicaid or are so debilitated that they are disabled and are covered by Medicare. And so being sure that they have access even to quality evidence-based care is a challenge in and of itself. And so those were all elements of this, let alone the challenges that often occurs in a disorder that affects children, where there's a lot of often good access to care, to then when they transition and become adults, and finding a medical home for these patients is a challenge. So really giving a holistic care is one of those the challenges that these individuals face as well.
No, it's something, oh, I'm sorry to interrupt. I was going to say it's something Mark McClellan has talked about a lot, that the public sector, private sector, academia, healthcare system, if it could be perceived as, if medical progress could be perceived as a system, so that since you know what the goal is, work back from the goal, not forward from the science necessarily, and kind of have everyone in that continuum. And of course, patients to say, that's nice, but it's not helping, you know. I think that's really great that it sounds like that's a system you had in your head as you were thinking about this.
Yeah, no, you're spot on, Ellie, that with the patient at the center, as you said, you then need all those players in the ecosystem to really improve care. So that literally goes from, as you were pointing out, those who are providing if you will, the coverage, which in this case is many cases the government, CMS, Medicaid, Medicare, but also those the care delivery and the systems. How do we make the care more continuous and not fragmented and emergency room driven? And then similarly, as you point out, how can that then be linked to implementation science, which we then fund to ensure that the system has optimized its strategies for that sort of holistic care.
Is that health services research too? Is that kind of another, or is health services research a part of implementation science?
I see them as a kind of a cluster. The implementation science, to me, more focuses on those processes of that align and strategies of actually operationalizing, making this work in the real world. So it's not just descriptive of these are how many people have Medicaid or this or that in a aggregate sense, but are we having treatment strategies that are at the provider level, at the patient level, and are enabling that care to actually be executed in the real world setting. And so there is a science to that as well, and the testing of different strategies that work to optimize and contextualize those things. But as you also said, the ecosystem does need the public-private partnerships with the academic researchers who are then either testing some of these strategies or in the laboratory, as you say, understanding the disease better. What drives the pain? Why is there a crisis? Does it relate to blood clots and what have you? And then studying those in depth, such that you actually know the molecule. And then clearly the private sector is critical, that given a good target, what are the therapeutic agents that can be developed and deployed? And as it turns out, one of the drugs that works well for a particular target, if it stops a blood clot, let's say in sickle cell disease, maybe it also stops a blood clot that may affect a heart attack or some other form of things. And so that's where the private sector can then look at where's the unmet need, and there's an opportunity to then connect that with sickle cell as an opportunity. And so it really takes the entire ecosystem. No one entity can do it all, but all are really necessary to provide the best patient-centered care.
That's what we try to say. So we're going to hire you now, Dr. Gibbons. I'm so sorry, NIH, but you have to come and talk instead of us because you just did such a beautiful job. So back to where progress is. So the children dying before age 5 is heartbreaking. And I also have to say the fact that progress has brought us to a place where maybe the average life expectancy is in the 60s is relative to US life expectancy. We've got a ways to go here too. Do you feel like there's some hope on the horizon?
Yeah, so again, we're encouraged about the wave of FDA-approved drugs that are enhancing the lives of those living with sickle cell disease.
And are those small molecule drugs or biologics or?
A mixture of both, And so the initiative that we started, Cure Sickle Cell, now several years ago, was to really extend what we hope will be transformative for these individuals is to actually cure it, since we now have the technologies of gene therapy, and particularly including gene editing, where if we know where a misspelling is in the DNA code, the technology now exists to go in and correct. And in particular for sickle cell disease, the ability to manipulate the stem cells, the cells that give birth, if you will, to the red blood cells. We know now how to manipulate that. So these are studies. It's not a pipe dream anymore. It was thought to be kind of a wide-eyed moonshot 9 years ago.
Wow.
But now this is within grasp. And indeed, the NHLBI is funding at least 2 phase 1/2 trials right now, where we're enrolling those with sickle cell disease to test out different gene therapy and gene editing technologies as we speak. And again, as part of the ecosystem, we've done that again in a very patient-centered way, with patients at the table from the beginning, in helping us to really map out this program. They're on our steering committee, their executive committee, and so they're helping to direct the whole initiative. It's involved patient groups like the Sickle Cell Disease Association of America and many other sickle cell groups in this process, and they've been fabulous in helping to do outreach and to public education, patient support, and pointing out things that we as clinicians and scientists often miss.
Right.
And so it's been a terrific collaboration across the entire ecosystem, again, including the private sector, where a number of biotech companies have stepped up and are exploring some of these new therapies. And so it's been a great collaborative partnership.
Victoria in the chat, just a question popped up from her, which is exactly the next one that I was going to ask you. As you were talking about gene therapies, gene editing, and I know that there are industry members. I think we have industry members actually that are working in I know we do in gene editing for different diseases. And then you get to Medicaid coverage and Medicare coverage, federal coverage programs. Is there a way to consider access? And it sounds like you're trying to in this, and consider that the costs of N of one medicine are high, right, relative to the cost of some other medicines, maybe not against the cost of hospitalizations and everything else that you might be avoiding, but how to confront that part of things so there's access.
No, it's a great, another great question, Elliot, and it's something that we anticipated at the beginning of the initiative, and indeed commissioned an expert group of health economists who then, working with academics and clinician scientists, as well as patients, sort of mapped out what is that journey like for those living with sickle cell disease. And as you can imagine, with all those, it being able to affect almost every organ in the body, causing strokes and kidney failure and heart and lung diseases, that in and of itself creates a number of conditions that require a lot of medical attention and therefore costs. And so the estimates are still being worked out, but that can be on the order of $1.5 to $2 million if you look cumulatively over time of what often happens to those living with sickle cell disease. So in that sense, to your point, if we can provide a transformative therapy that actually cures the disorder, even if that one treatment seems expensive on the front end, but prevents all those complications of renal failure and strokes and heart damage, and then in many ways it's probably the more cost-effective approach to addressing this. Not only is it transformative to the patients and gives them their lives back, not anxious about their next painful crisis, but also preventing all that organ damage.
That's right. There's got to be a way to make concrete the captured savings there. But I've noticed that there are many wonderful questions. I've co-opted a lot of your time and could do some more, but instead, Jacqueline, I think that you are joining us to pose questions today. Excellent. From the audience. So, and I know that we have a lot. If we don't get to all of them today, we'll try to get answers for those of you who we can't get, and Dr. Gibbons, we'd love to keep him here all day, but we probably can't. So we'll try to get you answers. And so with that, Jacqueline.
Great. Thank you, Ellie, and thanks, Dr. Gibbons, for this wonderful discussion so far. The first question from the audience, does NIH have opportunities to assist and or examine why an adult with sickle cell disease and alpha, I hope I'm saying this right, thalassemia, which is moderately severe disease course, is unable to tolerate almost all of the newly developed sickle cell disease drugs?
I think behind that question is a concern that although advances have been made and we're delighted about many of the new FDA-approved drugs, we still have a lot of work to do. And that, again, there are elements of the disorder that we haven't as effectively changed the natural history of the disease. May be able to affect certain episodes, reduce crises, and what have you, but we still have work to do, certainly on the pain front for sure. And that's where we have this parallel track with the curative agenda of gene therapy, as well as gene editing sort of strategies. And I might say that we also have what we hope is an even more ambitious goal, that in which recognizing that bone marrow transplant and its ability to cure has been around for probably 20, 25 years. But as you know, that involves a direct, often a match with a sibling or what have you. So only about 10 to 15% qualify for that. And that's one of the attractive features of the gene editing and gene therapy strategies, is that you can use the patient's own cells. But that does involve still bone marrow transplant, which is a very intensive treatment regime in which those patients get pretty sick, and it requires requires care in almost quaternary level academic centers. So not every hospital can do that. And so one of the more ambitious goals that the Cure Sickle Cell Initiative has is to actually even leapfrog that technology and move not only from what we call ex vivo, where we have to extract out the bone marrow cell and then manipulate it, but actually to think about actually developing strategies that take the gene editing technology into the body where it homes to that hematopoietic stem cell and then changes it within the body, so-called in vivo gene therapy in the body. And that may, that's the hope, is that may be something that could be done almost like a blood transfusion. At least that's the vision. And so that would not require the kind of intensive kind of treatment and care that current bone marrow transplant related approaches do. So that's still in the distance, on the horizon, but that's where we're hopeful. And the potential for that is that also may not only envision something that's safer, because it doesn't involve a lot of the toxic therapies that are involved with bone marrow transplant, but also is a way that may make it more accessible, because that's something that doesn't need a sophisticated hospital that are only a couple dozen in this country. That's something that could be done in a community hospital, perhaps even in a hospital in sub-Saharan Africa. So that's the vision, a one-shot in vivo gene therapy that's safe enough and accessible enough that it could actually reach and get to some of those children we talked about with that 50 to 80% mortality in 5 years. That's the hope. And indeed, we're funding basic science research that are already showing proof of principle that may not be as far off as some may think. That we might be able to leapfrog technology, working again in public-private partnership to really advance this in a way that it's really both safe and accessible to the widest possible population. That's the goal of this technology.
Wonderful. Thank you so much, Dr. Gibbons. Next question. Can you share any resources for assisting children with transitioning to adult sickle cell disease services?
Yeah, well, again, as a research agency, we fund strategies, and we do have had a implementation science program that has explored those. And so certainly they can probably get in touch with us at NHLBI, but there are strategies there. Similarly, we've collaborated with professional societies like the American Society of Hematology, that I know has an interest in this space as well, and they have elements of capturing that. And similarly, the Sickle Cell Disease Association of America also is a good touch point for patients looking for local care options.
You know, I was going to mention that not only in the United States has such terrific patient advocacy organizations, sickle cell specific, and then you have the National Minority Quality Forum. You have so many wonderful advocates. Great place to start with questions about care in particular. And there's some terrific questions in the chat that really merit answers. And they're on things like, what's the path to care for a child with SCT who's in pain and that kind of thing. And I want to make sure you get answers. And the patient community is such a great resource for that, or you can again always get in touch with us. The other thing I want to say real quickly is thank you to all of those who are just introducing yourself in the chat. Really appreciate it. I think the chat, only the panelists can see the chat because we get chatbot things from other countries and that kind of thing that pop in sometimes, but it's just lovely for you all to introduce yourself from all over the world that are joining us today. So thank you for that. Okay, I'll shut up again. Go ahead, Jacqueline.
Thanks, Ellie. All right, next question. Has the prevalence of sickle cell increased, decreased, or maintained at the current pace? Is there a particular reason why?
Yeah, so this, as we mentioned at the top, some of this relates to the prevalence of sickle cell trait. There's almost an advantage of that in places that have malaria. But for the most part, the population, for example, in the United States, has been hovering around 100,000, and that's been consistent. And we're also quite frankly hopeful that as we develop these new technologies of screening as well as treatment and hopefully cure, that again, more and more of that is accessible such that they're effectively treated. So I think that's the main message, is that we're hoping to expand the proportion of those living with sickle cells who are getting evidence-based care.
Wonderful, thank you. There's a few questions in Q&A about gene therapy, the new gene therapies that you were discussing. One in particular, when might gene editing therapy for sickle cell disease become a reality and part of routine care? What is a timeline on this?
Well, again, as with anything, we want to be sure that it's both safe and effective. And so that's where the Food and Drug Administration, the FDA, is very, very engaged, and this has been engaged with us, again, as part of the ecosystem from the very beginning, and sort of working through what is the best strategy and which ones are the safest and most efficacious. There are a number of different approaches. And so that's one of the reasons we're doing the trials that are currently enrolling. And so I think the future is very promising, that I believe we will have an FDA approved treatment, gene therapy treatment for sickle cell disease within a matter of years, for sure. I think those are within grasp. And we're very encouraged by trials that have already been done, some in the private sector that look very promising. And we know there are a number of them that are kind of in the queue, if you will. So we're seeing this as a matter of a few years before this is FDA approved and hopefully start to disseminate. But a key part of that dissemination, again, might relate to that leapfrog technology that may make it even more accessible in more contexts, that one-shot vision.
You know, I think that goes back to again, how important it is for the health research patient community here and globally to figure out access. Because once there's a cure, that cure needs to be available. And so, you know, it goes back to that double imperative: medical progress and access progress. So exciting.
Absolutely.
Yeah, it's wonderful to hear this optimism and progress. Okay, next question. Patients' distrust in the healthcare system is real and quite prevalent among this population. This has led to suboptimal care. I believe that this is one of the root problems. How shall we overcome this challenge?
Yeah, well, again, this is where we needed to work as an ecosystem, and particularly with patients at the center and patients at the table. And so that's one of the things that we've committed to in our initiatives. Again, literally trying to be as patient-centered as possible, both in the design and development of these programs and suggestions. Certainly, they've made it very clear. In fact, we recently had a retreat with our patient partners, and that's when they can tell us about challenges they're having, for example, in the emergency room or what have you, and where we can start to work through those strategies about, okay, how could we better provide care providers in the emergency room with the information they need to then have a more beneficial encounter with a sickle cell disease patient, such that that patient feels as though they've been heard and treated well. And so the models are being developed, including day hospitals and other sort of strategies that can make that experience of going through a crisis one that that again thinks of the whole patient and tries to do it in a way that preserves that dignity as well as provides good care. So looking at those models, and indeed, quite frankly, we're encouraged progress being made with CMS to even think about that in terms of how it reimburses care and looking at different care models. So again, we're hopeful that we can take a holistic view of this, and it's not only limited to the technologies of gene editing, but actually the technologies of providing just good care, including using mobile apps and other tools, electronic health record decision making, such that we can refine the care that's provided to patients living with sickle cell disease.
Jacqueline, if you don't mind me jumping in, there's a question here, and I put your MD hat on for a moment, Dr. Gibbons. A concern that's been raised is that there still are, and I think you've acknowledged this, we don't have the perfect protocols in place in healthcare settings to optimize the treatment, of sickle cell patients. And the question is there a possibility of accelerating the move from guidelines to where they are standard protocols? Could you flesh out that it sounds like a real problem here, but I'm not sure I have the context and we have the context.
Yeah, no, I think, again, a very insightful point that's being made, and you conveyed it. And that's where I was talking with that big term, implementation science. It's basically sometimes clinicians, the field knows what to do. It just is not getting done.
Not happening.
It's not happening. And so that's where I think that query is, the NHLBI is supported, the development of clinical guidelines and work with partners such as American Society of Hematology to do guidelines. Part of the challenge, though, is that living with sickle cell disease often aren't in the care of a specialist hematologist. Maybe
Right.
as a child they may have been, but when they move to adulthood, often they fall through the cracks, quite frankly, in our health system. And so they don't have necessarily folks who are specialists and understand sickle cell disease, know how to treat it, know all the guidelines, and know how to implement the guidelines. Similarly, if you just sort of show up in an emergency room, then often those physicians, as well trained as they are, may not be as well versed in sickle cell disease per se. And so that's where there can be this gap between what is known and the evidence guidelines that are in books and papers. But there you need somebody in the emergency room who understands. So that's where they're talking about those protocols. And literally, those are some of the research studies that are being testing some of these protocols. And that's why I mentioned even making an app such that maybe the patient, him or herself, would be able to call up that sort of protocol, perhaps even how best to treat their pain, because they've had these recurrent episodes. One of the questions and concerns that comes up is the use of opioids. And so, quite frankly, patients have encountered situations where, in essence, they've been undertreated because there's been a presumption that they're, quote unquote, drug seeking in some way, and or that the pain is being exaggerated. And so these are things that a protocol can help, but it's also raising that awareness and empowerment of patients.
Right.
That when they have these encounters, they can do that self-advocacy as well as again, helping the provider have that sensibility of how best to treat that. So that's a work in progress in the real world, as I say, in the implementation of these care, the best care.
It sounds like a place, and dare I say it, for AI, telemedicine. There's got to be a way, because again, this is a facet of medical progress. Just as implementation science is medical progress or the lack of it. And so really important. Do we only have you for 45 minutes? Horrifying. Could we get one more question answered?
Sure.
All right, one last question. This is a good way to end. How can patients and families get involved in research and clinical trials?
Oh, well, that's a fabulous good. So we're delighted because we see this as a collaborative partnership, and in many ways, it's one of the greatest gifts. We call it, social beneficence, to share in the finding of treatments and cures really begins and ends with the patients. And so we see patients as partners in the research. And so if you go to almost any of those sites related to either the NHLBI, the Sickle Cell Disease Association of America, or American Society of Hematology, all of them are engaged in facilitating the participation of patients in research, particularly research that's going to, we hope, ultimately benefit those patients. We really need that collaborative partnership.
Wonderful. And listen, if we can help in any way, Research America, we're glad to help navigate with you. We've done a lot of work with clinicaltrials.gov, and count us as your clinical trials buddy.
Okay. Yeah. Perfect. And we are enrolling in those curative therapies. Now, not everybody will necessarily qualify for every protocol, but again, these are active studies that are going on across the country and indeed the world.
Wonderful. Well, Dr. Gibbons, as always, we're just so thrilled whenever you can join us. And this was a really wonderful conversation. Cannot thank you enough for everything you're doing against so many diseases.
And well, we appreciate the collaborative partnership with Research America for sure. And what you do, it's a critical aspect that, again, helps the entire community and circle of partners in this ecosystem. So thank you for what Research America does.
Appreciate it. And Jay, I think we have Jacqueline, excuse me, Jay for short. I think we have a little bit of a few announcements coming up. So if you wouldn't mind taking over.
Yeah, so thank you all for tuning in and so much audience engagement. We really love to see it. So I'm gonna let everyone know about our next Alliance discussion next Wednesday, May 17th at 12 p.m. Eastern. I posted the registration link in the chat. We are featuring Stephen Grossman, the Executive Director of Alliance for a Stronger FDA. He will be discussing all things FDA, including recent developments bearing on FDA's role in the R&D ecosystem and the President's FY24 budget. So thanks again for joining us today, and we look forward to seeing you again. Have a great rest of your day.
Bye all. Thanks again, Dr. Gibbons.
Thank you. Bye-bye.